Mm. So it's 3, 2, 1. We are live to the audience. Over to you, ma'am.
A very good afternoon and warm welcome. I am Dr. Charvi Prajapati from Medical Affairs team of McLeod's Pharmaceutical. As we all know, that prevalence of diabetes is increasing worldwide, and India has second highest diabetic population in the world. So today we are here to understand on important anti-diabetic Vildegliptin and its combination with dapagliflozin. And in order to go further into the topic, we have with us Dr. Rohit Baijal as an esteemed speaker for the day. Sir is consultant diabetologist at VK Nadkari Hospital, Thakur Hospital, and Parik Nursing Home, Mumbai. Sir has over 20 years of clinical experience and has been part of many clinical trials as principal investigator. Sir is also member of prestigious organizations like EASD, ESC Heart Failure Association, and ACC. It's an honor to have you, sir. Now I hand over the session to you. Thank you so much.
I'll just share the slide. Can you see?
Yes, sir.
Right. So should we start?
Yes, sir.
Yes, sir. Yes, sir.
All right, fine. I'll on my video at the end of the presentation. All right.
Okay,
I've already
okay.
told Akshat.
Okay, sir. Sure.
Right. So a very good afternoon or an early evening to all the doctors joining for today's webcast on Vildegliptin plus dapagliflozin fixed drug combination. And thank you very much to McLeod's Pharmaceuticals Procare AHD division for giving me the opportunity to talk on today's topic. As I go along the presentation, as usual, from my side, some very interesting inputs which will be useful to all the attending doctors in their clinical practice. And today's presentation is dedicated to both my son and my wife, who are unfortunately COVID positive since the last 2 days. So this presentation is for both of them. Now, India accounts for 1 in 7 of all diabetics worldwide. India is the second highest country with the diabetes prevalence, with 74.2 million diabetics in the year 2021. A long-term glycemic control leads to improved outcomes. Every 1% decrease in HbA1c translates to a 43% reduction in lower extremity amputations or fatal peripheral vascular disease, 37% reduction in microvascular disease, 19% reduction in cataract extractions, 16% reduction in heart failure, 14% reduction in myocardial infarction, and a 12% reduction in stroke. Now, this is the ominous octet, which you must have seen multiple times. I would not go into the details of the ominous octet today. Let us see the mechanism of action of DPP-4 inhibitors in short. Now, active GLP-1, the pancreas, acts on the alpha cells and the beta cells. Now, via the beta cells causes glucose-dependent insulin secretion, which leads to increased glucose utilization by the muscle and the adipose tissue. Via the alpha cells causes glucagon suppression, which leads to decreased hepatic glucose release, improving overall glucose control. Active GLP-1 is converted to inactive GLP-1 via the DPP-4 enzyme. So DPP-4 inhibitors act on the DPP-4 enzyme and prevent this conversion from active to inactive GLP-1. Now, glucose reabsorption in the kidneys. This is a very busy slide. You can see the description on the right side, and you can follow the pictorial diagram on the left side. More than 90% of the glucose is reabsorbed from the glomerular filtrate into the epithelial cells via SGLT2 receptors or the sodium glucose cotransporter 2 receptors, which are present in the segment 1 of the proximal convoluted tubule, which you can see on the left side of the slide. Remainder of the glucose, that is less than 10%, is reabsorbed via the SGLT1 receptors, which are present in the segment 2 of the proximal convoluted tubule and the proximal straight tubule of segment 1, which you can also see on the left side of the slide. Now, glucose then passes into the interstitial fluid via GLUT2 or the glucose transporter 2, which is present in the segment 1, or via GLUT1, which is present in the segment 2 and segment 3. Now, the topic which we are talking about today, vildagliptin plus dapagliflozin, we should know is that dapagliflozin has got both SGLT2 and SGLT1 actions, including the SGLT2 inhibitor empagliflozin. But if you take the SGLT2 inhibitor canagliflozin, which has a predominantly SGLT1 action along with the SGLT2 receptor action, we should also know that SGLT1 receptors are mainly present in the gastrointestinal tract, especially the duodenum. And that's the reason why a drug like canagliflozin is supposed to be given before meals once or twice daily, mainly because of the SGLT1 receptor action of the drug, whereas the SGLT2 inhibitors like DAPA and empagliflozin and also ertugliflozin, which you do not have in India, are meal independent, which means you can give it either before or after meals. Now, let us see the mechanism of action of SGLT2 inhibitors. Now, SGLT2 inhibition causes reduction in glucose urea. Now, reduction in glucose urea causes reduction in weight, increased lipolysis, and increased gluconeogenesis. Reduction in glucose urea also leads to decreased total body sodium and water. Now, via the liver, reduction in steatosis and non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, reduction in blood pressure, especially systolic blood pressure, and reduction in angiotensinogen. Via the kidneys, reduction in hyperfiltration, reduction in intraglomerular pressure, and reduction in albuminuria, which causes reduction in fibrosis and reduction in chronic kidney disease progression. Now, via the heart, there is reduction in heart failure. Now, if you can see from the liver to the heart, you have got ketone bodies, and this is a very special mechanism of action of SGLT2 inhibitors. This mechanism of action was predominantly shown by Professor Dr. Silvio Inzicchi, who was the principal author of the EMPA-REG outcome study of canagliflozin, and after its presentation of ESC in 2015. The subsequent year, Professor Inzicchi showed this special mechanism of action of SGLT2 inhibitors via ketone bodies, and how ketone bodies are actually helpful for a diabetic patient. And I'll not go into the details of that today. And if you are interested to know about this special mechanism of action, there has been multiple publications by Dr. Inzicchi, which you can find in the Diabetes Care Journal. Let us see the American Diabetes Association 2022 guidelines, which you must have also seen before. If not, you can log into Diabetes Care of this year, the January issue, and you can do a download for free. Now, two groups, group one, where atherosclerotic cardiovascular disease or indicators of high risk heart failure and chronic kidney disease are present. Group one is further divided into three subgroups. One, where ASCVD or indicators of high risk are present. The drugs of choice after a metformin monotherapy are a GLP-1 receptor agonist with a proven CVD benefit, or an SGLT2 inhibitor with a proven CVD benefit. Two, where heart failure is present, the drugs of choice after a metformin monotherapy are an SGLT2 inhibitor with proven benefit in this population. And three, where chronic kidney disease is present. A chronic kidney disease and albuminuria, like more than 200 milligrams per gram of creatinine, the drugs of choice after metformin monotherapy are an SGLT2 inhibitor with primary evidence of reducing CKD progression, or an SGLT2 inhibitor with evidence of reducing CKD progression in cardiovascular outcome trials, or a GLP-1 receptor agonist with proven CVD benefit if the SGLT2 inhibitor is not tolerated or contraindicated. Chronic kidney disease without albuminuria, like an eGFR less than 60 ml per minute, the drugs of choice after a metformin monotherapy are either a GLP-1 receptor agonist or an SGLT2 inhibitor with proven cardiovascular disease benefit. Now, if you see the ADA guidelines of 2 years before, the first group was divided into two subgroups, and then in 2021, we had three subgroups where you have segregation of heart failure and chronic kidney disease. And this was predominantly done because of the various cardiovascular and renal outcome trials which have been presented in the last couple of years with SGLT2 inhibitors, especially the DAPA-HF trial and the DAPA-CKD trial of dapagliflozin, the Emperor Preserved and the Emperor Reduced trial of empagliflozin, and the Credence trial, which was the renal outcome trial of canagliflozin, which was presented in the World Congress of Nephrology of April 2019. So looking at all these various cardiovascular and renal outcome trials, the ADA went ahead and segregated the heart failure and chronic kidney disease group into two separate groups. Now, group 2 is also further divided into three subgroups. One, to minimize hypoglycemia, the drugs of choice after a metformin monotherapy are a DPP-4 inhibitor, an SGLT2 inhibitor, a GLP-1 receptor agonist, or a glitazone. Two, to minimize weight gain or promote weight loss, the drugs of choice after metformin monotherapy are a GLP-1 receptor agonist or an SGLT2 inhibitor. And three, consider cost and access. Consider insulins available at the lowest acquisition cost, or a sulfonylurea, especially modern sulfonylurias like a glycoside extended release or a glimepiride or a glitazone. Now, a linear plot of the linear plot between the innovator product T or Vildegliptin 100 milligrams once daily, which has been represented in the red line, and the reference product R or the innovator Vildegliptin 50 milligrams twice daily, which is represented in the blue line. Now, the linear concentration in nanograms per ml on the x-axis, where says the actual time from 0 to 24 hours on the y-axis. Now, if you see, the test product was bioequivalent to the reference formulation on the pharmacokinetic parameters over 24 hours. Now, the linear plot of mean percentage DPP-4 inhibition between the test product T or Vildegliptin 100 milligrams once daily, which is represented in the red line, and the reference product R or the innovator Vildegliptin 50 milligrams twice daily, which is represented in the blue line. The mean percentage DPP-4 inhibition from baseline on the x-axis versus the actual time from 0 to 72 hours on the y-axis. Now, if you see a similar mean percentage DPP-4 inhibition between the test product and the innovator product from 0 to 72 hours. Now, weighted average percentage DPP-4 inhibition, again, between the test product T or Vildegliptin 100 milligrams once daily, which is represented in the pink bar, and the reference product R or the innovator Vildegliptin 50 milligrams twice daily, which is represented in the blue bar. Now, the average percentage DPP-4 inhibition was similar between the test product T and the innovator product R, 85.28 versus 86.79. Now, Vildegliptin 100 milligrams sustained release is given once daily. It is not recommended if the creatinine clearance is less than 50 ml per minute, and it can be given either with or without meals, so it is meal independent. Now, Vildegliptin reduces glycemic variability. Now, MAGE, or the mean amplitude of glycemic excursions on the left side of the slide, a significant reduction in the mean amplitude of glycemic excursions from 93.8 milligrams per deciliter at baseline to 70.8 milligrams per deciliter at 16 weeks. Standard deviation of 24-hour glucose on the right side of the slide, a significant reduction in the standard deviation of 24-hour glucose from 38 at baseline to 27.7 at 16 weeks. Now, Vildegliptin lowers albuminuria in patients with type 2 diabetes and hypertension independent of the glycemic control. A significant reduction in albuminuria in type 2 diabetic and hypertensive patients who were responders to HbA1c with improved urine albumin creatinine ratio by 20%, which you can see in the yellow bar as compared to only 9% with the control. Significant improvement or a reduction in the rate of change of urine albumin creatinine ratio with Vildegliptin as compared to placebo, which you can see on the right side of the slide. Now, meta-analysis of Vildegliptin on cardiovascular outcome trials. 40 studies with phase 3 and phase 4 studies with more than 17,000 plus patients. 9,599 patients in the Vildegliptin arm as compared to 7,847 patients in the comparator arm. The mean age was 57 years. Mean HbA1c was 8.1%, and the mean diabetes duration was 5.5 years. Approximately 50% patients had high cardiovascular risk, 18% patients had a history of cardiovascular disease, and more than 40% patients had a renal impairment. Now, primary composite outcome was non-fatal MI, non-fatal stroke, or cardiovascular death. Secondary composite outcomes included non-fatal MI, non-fatal stroke, cardiovascular death, or heart failure events. Now, primary composite outcome, no increased risk was seen with Vildegliptin. A significant reduction in the MACE composite outcome, myocardial infarction, stroke, and cardiovascular death, with hazard ratios ranging from 0.77 for cardiovascular death to 0.87 for myocardial infarction in favor of Vildegliptin. So we come to the VIVID trial. Now, VIVID trial has been a bone of contention for Vildegliptin, as the other pharmaceutical companies have shown or talk about the heart failure events with Vildegliptin from the VIVID trial. The VIVID trial was presented by Professor Dr. John McMurray, who was also the principal author of the DAPA-HF trial of dapagliflozin. Now, the VIVID trial included 254 patients with Vildegliptin versus placebo, 18 to 85 years of age with type 2 diabetes, with a heart failure with a reduced ejection fraction, NYHA class 1 to class 3. A duration of 1 year. Primary endpoint was the between treatment change from baseline in the left ventricular ejection fraction. Takeaway, compared with placebo, Vildegliptin had no major effect on the left ventricular ejection fraction. The mean change in left ventricular ejection fraction versus placebo and Vildegliptin. Now, similar mean change in the left ventricular ejection fraction between the two groups, 4.3% for placebo versus 4.95% with Vildegliptin. So as you can see, there has been no significant side effects with Vildegliptin on the left ventricular ejection fraction in patients with heart failure. Now, before I go ahead this presentation, I would also like to talk two important presentations of Vildegliptin. Unfortunately, I would not be able to show you on the slides, so I will tell you to you in audio. And the first important input is from the recently concluded American Diabetes Association of this month, which was from 3rd to 7th of June in New Orleans. And this was a very interesting presentation of Vildegliptin, the clinical relevant predictors of cardiovascular events, exploratory analysis from the VERIFY study of initial treatment of type 2 diabetes. Let me tell you this ADA presentation in short. The VERIFY study of the primary treatment in type 2 diabetes showed delayed glycemic failure with an HbA1c of more than 7% at 2 consecutive scheduled visits post-randomization with early combination of Vildegliptin and metformin, or the early combination arm versus the initial monotherapy arm in patients with newly diagnosed type 2 diabetes with an HbA1c between 6.5 to 7.5%, which all of you must definitely be knowing by now. Now, throughout the 5-year study, 57 adjudicated cardiovascular events were collected, but the study was not powered to test the hypothesis that early combination was able to decrease cardiovascular events. So the authors explored whether simple clinical data at type 2 diabetes onset with a Framingham risk equation or cardiovascular disease history could identify patients at the risk of subsequent cardiovascular events. At baseline, the Framingham risk score was 14.9 plus or minus 9.2%, and 12.3% patients had a cardiovascular disease history. A significant higher risk in patients with a cardiovascular disease history and a Framingham risk score of more than 20% was visually apparent on the Kaplan-Meier curves and the log rank test. A baseline HbA1c, age, and gender were not significantly associated with cardiovascular outcomes, whereas the treatment failure within the first 3 years was significantly associated with a higher risk of cardiovascular events. So these analyses suggest that both cardiovascular risk stratification at onset of type 2 diabetes and the early loss of glycemic control may identify patients at a higher risk of subsequent cardiovascular events. Again, if you would like to have this presentation of Vildegliptin from this year's ADA, you could contact McLeod's Pharmaceuticals. They would be more than happy if they have got this presentation, or I would provide the presentation to them, and the participants can take this presentation from McLeod's. The second one also is a very interesting presentation, and you can find this presentation or this publication in BMC cardiovascular disorders, and I had presented it also on behalf of Novartis for Galvus last year, and I thought today also would be an appropriate time to talk about this study in short for today's audience. And this is the impact of vildagliptin on the daily glucose profile and coronary plaque stability in impaired glucose tolerance patients with coronary artery disease, or the VOGUE-A multi-center randomized controlled trial. This was published last year. Now, the impact of reduction in glycemic excursions on coronary plaque remains unknown. So the VOGUE study aimed to elucidate whether DPP-4 inhibitor vildagliptin could reduce glycemic excursions and stabilize the coronary plaques compared with the conventional management in coronary artery disease patients with impaired glucose tolerance. So the VOGUE study was a multi-center randomized controlled trial including CAD patients with impaired glucose tolerance under lipid-lowering therapy receiving either vildagliptin 50 milligrams once daily or no medication or the control group. Regarding glycemic treatment, the primary endpoint was change in the minimum fibrous cap thickness and the lipid arc in non-significant native coronary plaques detected by optical coherence tomography at 6 months after intervention. The glycemic variability was expressed as the mean amplitude of glycemic excursions measured with continuous glucose monitoring systems was evaluated before and 6 months after intervention. Now, a total of 20 participants with 47 lesions were allocated to either vildagliptin, 10 participants with 22 lesions, or the control group, 10 participants with 25 lesions. The adjusted difference of the mean change between the groups is minus 18.8 milligrams per deciliter for MAGE, vildagliptin minus 20.1 plus or minus 18 milligrams per deciliter versus control 2.6 plus or minus 12.7 milligrams per deciliter. Minus 22.8 degrees for the mean lipid arc, vildagliptin minus 9 plus or minus 25.5 degrees versus control 15.8 plus or minus 16.8 degrees, and 42.7 microns for the minimum fibrous cap thickness, vildagliptin 35.7 plus or minus 50.8 microns versus control 15.1 plus or minus 25.2 microns. So in conclusions of this VOGUE trial, vildagliptin could reduce the mean amplitude of glycemic excursions at 6 months and may be associated with decreased lipid arc and increase the minimum fibrous cap thickness of the coronary plaques in coronary artery disease patients with impaired glucose tolerance as compared to the control group. So if you would like to have the full text of the publication, you could go to BMC Cardiovascular Disorders and you could take a printout of the same. Let's go ahead in today's presentation, and we come to the very important Declare-TIMI 58 study of dapagliflozin, which you must have definitely seen in the last many years, and we'll just talk one slide on Declare-TIMI 58. The cardiovascular death or hospitalization for heart failure on the left side of the slide. A significant reduction in CV death or hospitalization for heart failure with an hazard ratio of 0.83 or a 17% relative risk reduction with dapagliflozin 10 milligrams versus placebo. Now, if you see the Kaplan-Meier curves between dapagliflozin 10 milligrams in the blue line versus placebo in the red line, you would see that the Kaplan-Meier curves start to diverge right from the baseline of the study, and they were completely divergent by around 540 days of the study period. Renal composite on the right side of the slide, a significant improvement in the renal composite with a hazard ratio of 0.76 or a 24% relative risk reduction with dapagliflozin 10 milligrams versus placebo. Again, if you see the Kaplan-Meier curves between dapagliflozin 10 milligrams in the blue line and placebo in the red line, you would see that the Kaplan-Meier curves were similar from the baseline to 540 days of the study. Then the Kaplan-Meier curves start to diverge, and they were completely divergent by 900 days of the study period. Now, again, here I'll tell you two very important things. The latest presentations about dapagliflozin. Again, I would not be able to show you in a slide, and I'll talk to you on audio in short. The first one is from the recently concluded ESH, or the European Society of Hypertension, which was from 17th to 20th of June, so just recently concluded in Athens, Greece. There were a couple of presentations on dapagliflozin, and I'll just talk to you one in short. And this was the effect of dapagliflozin on the level of systolic blood pressure and glycemic control in patients with arterial hypertension and type 2 diabetes. Now, let us see this presentation of ESH in short. Now, the objective was to determine the influence of dapagliflozin on the level of blood pressure in patients with arterial hypertension and type 2 diabetes. A total of 57 patients with arterial hypertension stage 2 and concomitant non-severe type 2 diabetes were examined with a fasting plasma glucose less than 9 millimoles per liter, HbA1c of 7.4 plus or minus 1.3%, mean age of 52.4 plus or minus 2.8 years, mean blood pressure of 162 by 102 millimeters of mercury, mean body mass index of 28.3 plus or minus 2.7 kgs per meter square, mean disease duration of 6.6 plus or minus 1.7 years. The patients were divided into two groups. The comparison group included 23 patients who received metformin 850 milligrams twice daily, lisinopril 10 milligrams once daily, and amlodipine 10 milligrams once daily. The patients on the main group or the dapagliflozin group received dapagliflozin 10 milligrams in addition to standard therapy. Now, 6 months after beginning of therapy, the following results were obtained. Now, HbA1c in the dapagliflozin group was 6.2 plus or minus 0.6%. In the comparison group, 6.5 plus or minus 0.48%. A slight decrease of BMI was observed in both group, 26.3 plus or minus 1.2 kgs per meter square and 27.4 plus or minus 1.3 kgs per meter square respectively. However, these changes were insignificant. Systolic blood pressure in the dapagliflozin group was 132 plus or minus 7.2 millimeters of mercury, and in the comparison group, 145.5 plus or minus 9.1 millimeters of mercury. The diastolic blood pressure was 83.5 plus or minus 3 millimeters of mercury and 89.6 plus or minus 4.2 millimeters of mercury. So in conclusions of this ESH presentation, the data obtained demonstrated that adding dapagliflozin to a standard therapy of hypertension and concomitant type 2 diabetes leads both to significant decrease in systolic blood pressure and improvement of glycemic control. The outcomes of the research suggest that dapagliflozin has a potential to reduce cardiovascular risk in hypertensive patients with type 2 diabetes. And the other one also is a very important presentation. And this was again from this year's ADA from 3 to 7th of June in New Orleans. There were not many presentations of dapagliflozin, but I will talk to you one of them. And this was the efficacy of dapagliflozin by baseline diabetes medications. And this was a pre-specified analysis from the DAPA-CKD trial. So I will talk about this ADA presentation in short. Now, the authors enrolled participants with chronic kidney disease with an eGFR between 25 to 75 ml per minute and a UACR between 200 to 5,000 milligrams per gram of creatinine, and included those with type 2 diabetes at baseline in this analysis. The primary endpoint was a composite of sustained decline in eGFR of more than 50%, end-stage renal disease, or death from kidney or cardiovascular causes. Secondary outcomes included the kidney-specific composite, the same as the primary outcome, but without cardiovascular death, composite of hospitalizations for heart failure, CV mortality, and all-cause mortality. Now, the authors determine the effects of dapagliflozin compared with placebo in subgroups by the use or not of diabetes drug classes at baseline, metformin, sulfonylureas, DPP-4 inhibitors, GLP-1 receptor agonist, and insulin, and by the number of diabetes medications at baseline. Now, of the 4,304 participants enrolled, 68% had type 2 diabetes, of which 55% were on insulin, 43% were on metformin, 27% were on sulfonylureas, 26% were on DPP-4 inhibitors, and 4% were on GLP-1 receptor agonist. Now, at baseline, 11% were without diabetes treatment, 50% were treated with one diabetes drug, 32% with two drugs, and 7% with three or more drugs. The effect of dapagliflozin on the primary composite outcome was consistent across the comparisons of the baseline diabetes drugs, and according to the number of drugs. So the authors found a consistent benefit of dapagliflozin compared to placebo on the secondary outcomes, regardless of the background drug classes or the number of drugs. So in conclusions of this ADA presentation of the DAPA-CKD study, dapagliflozin reduced kidney and cardiovascular events in type 2 diabetes with chronic kidney disease independent of the baseline diabetes drug class or by number. And again, if you would like to have this ADA presentation of dapagliflozin, you could contact MacLeod's Pharmaceuticals, who would be more than happy to give you this presentation. Let us see the rationale for the combination of now vildagliptin plus dapagliflozin. Reason one, multiple targets in the ominous octet are covered. SGLT2 inhibitors increase renal glucose reabsorption, whereas DPP4 inhibitors increase gluconeogenesis, decrease insulin secretion via the beta cells of the pancreas, and increase glucagon secretion via the alpha cells of the pancreas. Reason two, dapagliflozin has an insulin independent or a beta cell independent mechanism of action, which increases glucagon and increases hepatic glucose output. Whereas vildagliptin acts on the alpha cells of the pancreas, which decreases glucagon and decreases hepatic glucose output. So combined together, vildagliptin will tackle the glucagon surge that may occur due to dapagliflozin. Now, does prescribing a drug twice daily impact the compliance? Now, let us see a meta-analysis of 13 studies, and this meta-analysis was published way back in 2013. The impact of reducing the dosing frequency on the adherence to oral therapies, literature review and meta-analysis. Now, across acute and chronic disease states, reducing the dosage frequency from multiple dosing to once daily dosing may improve the adherence to therapies among patients. Improving adherence may result in subsequent decreases in the healthcare cost as well. Finally, reason three, both are to be given once daily according to the pharmacokinetic and the pharmacodynamic profiles of both the drugs. Now, lesser incidence of genitourinary tract infections with the use of a SGLT2 and a DPP4 inhibitor fixed drug combination, a significant reduction in the genitourinary tract infections with hazard ratios ranging from 0.06 in the Rosenstock study to 1.04 in the Tina-Hone study. The overall hazard ratio was 0.80, or a 20% relative risk reduction in the genitourinary tract infections in favor of a SGLT2 plus a DPP4 inhibitor fixed drug combination. Now, let us see the management of type 2 diabetes based on glycemic factors with the use of fixed drug combinations. We should initiate with lifestyle modification. Now, one, in treatment-naive patients where metformin is either contraindicated or intolerant and the HbA1c is more than 8%. Two, in treatment-naive patients with metformin in combination with metformin in patients where the baseline HbA1c is more than 9%. And three, patients uncontrolled on metformin monotherapy. In patients who are uncontrolled with metformin monotherapy and the HbA1c is more than 8.5%. And finally, to end today's presentation of mine, both SGLT2 inhibitors and DPP4 inhibitor fixed dose combinations are a suitable option for Indian type 2 diabetic patients. Safer, rapid, and sustained glycemic control. They improve both insulin resistance and beta cell function, help reduce body weight and blood pressure due to the extra glycemic benefits of SGLT2 inhibitors, reduce pill burden, which improves the adherence and compliance. And finally, they are cost-effective therapies. So with that, I would end, ladies and gentlemen. Thank you very much for your patient listening.
Thank you very much, sir, for the detailed presentation. And now
Let
we are
me,
open to questions.
yeah, just
Awesome.
let me. Yeah, I'm sorry for the mask,
No
but
issues, sir. Yes, no
I have
issues.
to do it in view
Yes.
of the home isolation of both my wife and my son.
Yes, sir, we understand. Thank you, sir, for taking a very detailed presentation. So, few questions.
Sure.
So, where do you, so in your clinical practice, where do you place this combination of Vildegliptin and dapagliflozin in your clinical practice?
Again, I mean, if you see today's presentation, it has been highlighted
Yes.
at the end, which are some of the indications where you can use a fixed dose combination of these two drugs. And if clinicians are basically following GDMTs or guideline directed medical therapies, especially of ADA and of AACE, then they should basically understand the treatment algorithm. We have also spoken about in details the ADA algorithm of this year. It is almost similar like the ADA algorithm of last year. But what people should also understand is basically the the AACE guidelines, which are very different from the ADA guidelines. And just to make today's audience a little aware of the AACE, or the American Association of Clinical Endocrinology guidelines, predominantly they are divided into three groups according to the HbA1cs. One where the HbA1c is less than 7.5%. You start off with a monotherapy, and the drugs in the descending order can be a metformin, a GLP-1 receptor agonist, an SGLT2 inhibitor, or a DPP-4 inhibitor. You could use any of these four drugs if the person is intolerant or is contraindicated to a metformin. You can use the other three drugs as a monotherapy. Now, if the HbA1c is more than 7.5%, you start off basically with a dual drug therapy. Again, the same four drugs in the descending order, and you can use any of the two combinations and permutations of those four drugs. And when the HbA1c is more than 9.5%, here you either start with a dual or a triple drug therapy. Again, you choose from the four classes of drugs, depending upon the permutation and combinations what you would like to use. If you are going to see basically according to the ominous octet or the pathophysiological defects of type 2 diabetes, which again we have spoken today, then the clinicians should understand that both these two classes of drugs have got multiple benefits on the ominous octet, and they will be a very suitable option for people who are uncontrolled, who are having a high baseline HbA1c, maybe on a monotherapy anti-diabetic drug. And again, a combination of these two drugs, as we have seen as a fixed dose combination, has got multiple benefits, cost effective, and obviously you are following the GDMTs, and you are also going to take the patients close to their glycemic targets with multiple cardiovascular and renal benefits. I have spoken about the recent ESH and the ADA presentations. Unfortunately, I was not able to show it in a slide, but some other time in some presentation, why not? But again, those ADA presentations and the ESH presentation also, have highlighted, all the benefits of using these two drugs, maybe individually on cardiovascular and renal parameters. There was again a very interesting presentation which was done in ESH, or the European Society of Hypertension, on dapagliflozin. Unfortunately, I was not able to talk. I'll just tell you in short. And this was basically on the usage of dapagliflozin on serum homocysteine levels. What happened is that the authors went on and they saw the effects of dapagliflozin 10 milligrams versus folic acid on serum homocysteine levels. And we know that serum homocysteine levels is one of the markers basically for cardiovascular disease. and now basically we have only folic acid, which generally is used in people, in reducing homocysteine levels. So they compared both these two drugs in this class of patients, and what they found out was dapagliflozin definitely has more beneficial effects, in reducing serum homocysteine levels as compared to folic acid. So this is again a new dimension of using dapagliflozin, in reducing homocysteine. So if you're using a drug like dapagliflozin in a fixed dose combination with vildegliptin, it has got multiple benefits which you can offer to your patients. So you have got the cardiovascular, you have got the renal, you have seen basically on arterial hypertension, which was one of the extra glycemic effects, but now it has been proven in the Esh presentation. And now you have basically this additional thing on serum homocysteine levels. So multiple benefits of using this drug. And yes, and again, we know that adherence and compliance is a big issue in our country. So if you give a drug which is once daily, with multiple benefits, and which is cost effective, why not? And in my clinical practice, I have used this combination in my patients, and they have really responded very well. Pill burden has gone down, and the glycemic control has been very appreciable, and the patients have definitely seen a once daily pill with this kind of a combination, how it has benefited their glycemic control. And ultimately, what a person would ultimately want in a in a diabetic practice as a clinician, as an investigator, we see one very important part, in the glycemic hexad, and that is basically improving the quality of life. And being an investigator of various national and international trials, quality of life is a very important parameter. And then if you see something like this, improving the quality of life, things speak for itself.
Sure, sir. Thank you so much for that detailed answer. And just one last question. So in terms of side effect, genitourinary infection, has this combination caused, reduced the incidence of the same?
I think so. That has been shown in today's presentation, also in the one of the slides at the end, that how it has reduced genitourinary tract infections. It is basically because of the complementary mechanism of action of both these two drug classes. Again, with SGLT2 inhibitors, we know that there are high incidences, especially of genital tract infections as compared to urinary tract infections. Asymptomatic bacteriuria or asymptomatic bacteriuria in terms of urinary tract infections is a very common side effect which has been encountered in women, type 2 diabetics. So generally testing patients, with a routine urine examination should be done by all clinicians while they are putting a patient basically on an SGLT2 inhibitor. If not, then definitely a urine routine should be done on a follow-up. You could see two very important things in that. One is basically to see if the patient is having an asymptomatic bacteriuria, or basically the patient is getting prone to a urinary tract infection. And two is basically which people always ask, that you see urine glucose is being 2 positive, 3 positive, when the blood glucose levels go down. And that is a very important marker which clinicians should understand, and you should try and tell your patients, is that the drug is working very well because it causes glucoseuria. So when glucose comes out, definitely you would see this present 2 plus or 3 plus, which is a very good sign. There's nothing wrong when you're on SGLT2 inhibitor, and you should try and tell that the drug is working very well for you. Again, on the hindsight, you also have patients which have seen in the last 7 years being on SGLT2 inhibitors who are non-responders, maybe basically because they are not having very active SGLT2 receptor inhibitions. So that is the reason why you have some failures, or you have some non-responders to SGLT2 inhibitors. And there have been a very few handful of them which I've seen in the last 7 years. But on a majority, yes, these are something very important. Again, something which is, which is there in the package insert, which people should understand, and people should try and educate their people in reducing this genital urinary tract infection, is on education. On a very important part is, the necrotizing fasciitis of the perineum, and which again, at least I have not seen up till now. But yes, this necrotizing fasciitis of the perineum is a very, very important side effect which has been encountered with SGLT2 inhibitors. So personal hygiene is of prime importance. And if you do get, I haven't seen up till now, but that doesn't mean that people cannot get, this side effect with SGLT2 inhibitors, but being vigilant and talking to your patients when they come on a follow-up, and at least educating them on certain very personal hygiene issues will be very important in reducing these genital urinary tract infections in the long run.
Yes, sir. And so, what would be your final message or final thought for our audience today?
Final thought for today basically is that try and use these fixed dose combinations. If still not used, I think so. It will be advisable to use in a few patients. See how good or otherwise this combination is, which you can offer to your patient. Multiple beneficial effects, cost effective, compliant, and ultimately improving quality of life. So that is the ultimate thing which a clinician would want to see their patients when you prescribe a drug like these. So go ahead, use for a few patients and see how good or otherwise this FDC is of.
So, with this, we come to end of the session, sir. So we thank you, doctor, for taking a very elaborate session and sharing your clinical insights. That was really helpful. We also thank our audience for joining in. And lastly, we thank our technology partner for smooth streaming of the session. Thank you so much, sir.
Thank you very much, and a very good evening to all participants joining. And thank you to McLeod's Pharmaceuticals. Stay healthy, stay safe. Some other time, but without the mask. Bye. God bless.
Thank you.
Bye. Have a good day, sir. So with the permission, shall we conclude, ma'am?
Yes, sir, we can end the session.
Okay. Thank you. So from here, now I'm ending this meeting.